Today, we're navigating a really vital process in healthcare: the precise setup of mechanical ventilators for patients in the intensive care unit. This intervention, well, it saves lives, but getting it absolutely right is everything for the patient.
It really is remarkable, isn't it, how a structured, systematic approach significantly reduces risk and really improves patient outcomes. For you healthcare providers listening, understanding each specific step ensures optimal oxygen delivery and actively prevents complications. It's about being methodical.
Exactly. This information is really designed for you, the healthcare provider. Whether you're perhaps new to the intensive care unit or maybe just seeking a concise but thorough refresher, we're going to extract the most important insights from a step-by-step guide on setting up ventilators. Our goal: to give you clear, actionable knowledge you can use immediately at the bedside. Okay, so before any connection happens, two big areas demand your complete attention: the patient themselves and, of course, all the necessary equipment. Readiness on both these fronts is, well, it's absolutely non-negotiable.
And that brings up a really important point. What specific patient checks are essential before you even think about connecting that ventilator? What are the absolute key elements we must confirm for patient readiness?
Okay, for patient readiness, the very first requirement is confirming the patient is intubated. That's the absolute prerequisite, right? Without a secure endotracheal tube in place, mechanical ventilation just cannot happen safely or effectively. The airway has to be established first. Simple as that.
Precisely. And once intubation is confirmed, you absolutely must ensure the endotracheal tube is securely placed. Stability is vital here. It prevents accidental dislodgement, which, can lead to immediate respiratory distress or even worse. A tube that moves or isn't properly secured, well, it risks shifting right out of the trachea. That means all the ventilation you're trying to deliver is lost. This usually involves taping the tube securely to the patient's face and making sure those correct depth markings are visible right at the lip or the gum line.
Right, makes sense. And beyond just the tube itself, what about the patient's state, their comfort, their cooperation with the machine?
Yes, verifying the patient is adequately sedated is paramount. And this goes way beyond just comfort. It ensures the patient actually cooperates with the ventilator, actively preventing them from, fighting against the machine. That can lead to asynchronous breathing patterns, patient-ventilator dysynchrony. It's not good. Proper sedation also significantly cuts down the risk for self-extubation. That's a major, potentially life-threatening event where the patient pulls out their own breathing tube. So a calm patient allows for optimal ventilation delivery and reduces their overall physiological stress. You need to be assessing their level of consciousness and pain continuously.
Okay, so once a patient side is thoroughly addressed, checked off the list, our focus shifts. The equipment assessment is just as vital, isn't it? It's really about proactively preventing problems before they even get a chance to start.
Indeed it is. So what are the key equipment checks that you, the healthcare provider, should be performing? This is where that meticulous attention to detail really, really pays off.
Let's start with the ventilator itself, the machine. What are we looking for there?
First off, verify that the ventilator itself is intact and fully functional. What does that mean? It means it should successfully complete its internal self-tests, or its power-on diagnostics, without any errors popping up. These self-tests are pretty comprehensive internal system checks. They verify everything from circuit integrity to sensor calibration, alarm functions, the works. If the ventilator fails its self-test, that indicates some kind of software or hardware malfunction. That specific machine is not safe for patient use, period. You'd need to tag it for repair, get another ventilator. This initial check is just a fundamental safety gate.
Okay, fundamental safety gate. Got it. Next up, the gas supplies. These are quite literally the essential elements, the lifeblood of the system. How do we check those?
Right. You absolutely must check that the oxygen and the medical air supplies are securely connected to the ventilator. These are usually high-pressure hoses, right? They attach to specific ports, typically on the back of the machine. Loose connections can lead to insufficient gas delivery or even a complete loss of gas flow. That would basically render the ventilator useless. And beyond just checking the connection, you need to confirm these gas supplies are functioning correctly. Are they providing consistent flow, appropriate pressure? This usually involves checking the pressure gauges, either on the wall outlets or maybe the gas cylinders themselves. You need to ensure they're delivering the required pressure. That's typically between 50 and 60 pounds per square inch, or psi, to the ventilator. Without adequate pressure and flow, the ventilator just can't deliver the prescribed gas mixtures or volumes. And that puts the patient at risk of hypoxemia or hypercapnia.
Makes sense. And what about managing the patient's airway beyond just the ventilator circuit itself? What immediate tools do we absolutely need right there on hand for unexpected needs?
Good question. You must have suction equipment readily available and already set up. This is absolutely essential. Why? Because airway clearance needs can arise suddenly. Patients on mechanical ventilation, they often produce increased secretions. Prompt, effective suctioning can prevent airway obstruction, maintain the tube's patency, and reduce the risk of ventilator-associated pneumonia. So this means having a suction machine ready, sterile suction catheters of the right size, and a Yankauer suction tip right there at the bedside. It's a critical safety measure. Immediate removal of anything blocking the airway.
Okay, suction ready. And for the most unexpected, the worst-case scenarios, what emergency equipment must be within arm's reach, ready for instant use?
You must ensure emergency equipment is within immediate reach, no question. This includes an ambu bag, that's the manual resuscitator, also known as a bag valve mask, ready for manual ventilation instantly. Additionally, various airway adjuncts like oral airways, nasal airways, maybe even a spare endotracheal tube should be right there, easily accessible. Think about it. If the ventilator fails, or if the patient gets disconnected, or the tube gets dislodged, you need to be able to manually ventilate that patient instantly. Maintain oxygenation, maintain ventilation. This immediate readiness, it's just non-negotiable for patient safety, the core part of emergency preparedness in the intensive care unit.
Wow. So this whole preparation phase is incredibly comprehensive. It really covers everything, from ensuring the patient is stable and ready to verifying the machine's integrity and even preparing for any emergency. It truly sets the foundation for a safe ventilator connection.
Absolutely. Every single one of these preparatory steps plays a vital role in minimizing risks and ensuring a smooth, safe transition to mechanical ventilation. Skipping any of them, that can have immediate and severe consequences for the patient. It really is the groundwork that supports every single step that follows.
Right. So with all those pre-checks ticked off, what are the first hands-on steps with the ventilator itself? It's time to, bring the machine to life and assemble its components so it's ready to actually deliver those breaths.
Exactly. The power-up sequence and the precise assembly of the breathing circuit are foundational here. Foundational. Any misstep at this stage can compromise the entire process of ventilation and, crucially, the patient's safety. These are the critical building blocks before you even think about the actual patient connection.
Okay, let's begin with powering on the device. What's the correct sequence for starting the ventilator? Seems simple, but let's cover it.
Right. First step, power on the ventilator. Seems basic, I know, but it's the gateway to everything else. Immediately after powering up, it is imperative, absolutely imperative, to allow the machine to complete its internal self-diagnostics without any interruption. This isn't just a quick flicker of lights or a beep, it's a comprehensive internal system check. The ventilator verifies everything: its internal circuit integrity, sensor calibration, alarm functionality, the lot. If it fails this self-diagnostic process, that specific machine is absolutely not safe for patient use. It signals a fundamental problem, something for biomedical engineering to look at. The successful self-test is an essential internal quality check, confirming the ventilator is ready for operation.
Okay, so the machine has done its vital self-checks, confirmed its own integrity. What about putting together the breathing circuit? This is the part that physically delivers the conditioned air to the patient, right?
Correct. You must attach the breathing circuit components precisely according to the manufacturer's instructions. This circuit is complex, and it's critical. It typically includes the main ventilator tubing that carries the inspiratory and expiratory gases. It also includes either a humidifier or what's called a heat and moisture exchanger filter. These condition the air, add warmth and moisture. Proper humidification is vital. It prevents drying and damage to the patient's airways, and additionally, an inline bacterial filter is often included. This prevents microorganisms passing into or out of the circuit. Every connection must be secure, leak-free. Proper assembly ensures the patient receives sterile, appropriately humidified gas. That's fundamental for lung health and preventing complications like airway irritation or infection.
That attention to detail on the circuit is very clear. What about the gas supplies again at this stage? We checked them earlier, but what's the final connection step before it's fully ready?
Good point. After assembling the entire breathing circuit, you have to ensure the high-pressure hoses for oxygen and medical air are firmly attached to the ventilator's gas inlets. These are the main lifelines, connecting the hospital's gas supply right to the machine. Loose connections at this point, they can lead to immediate ventilation failure, insufficient gas delivery to the patient. So verify the connections are tight, and maybe give them a quick pull test and that there are no audible gas leaks. None. This final connection point is the direct link between the gas source and the patient's breathing circuit. Its integrity is paramount for continuous, effective gas delivery.
Okay, so we've powered it on, the machine's running its internal checks, the breathing circuit is meticulously assembled, and the gas lines are securely connected. It sounds like the ventilator is now physically ready for initial programming and then connection to the patient.
Exactly right. These steps, taken together, create a fully functional and ready ventilation system.
All right, here's where the clinical practice truly kicks in. Establishing those initial parameters. What are the common choices for modes and settings for adult patients in the intensive care unit? Where do you typically start?
Yeah, this brings up an important distinction, really, between standardization and customization. For most adult intensive care unit patients, beginning with a common starting point simplifies the initial approach. It gives you a reliable baseline before you make those individual patient adjustments.
Okay, let's talk about the ventilation mode first.
Yeah.
What are the common initial choices for how the ventilator actually delivers breaths?
So, volume-controlled, sometimes called VC or assist control modes, often abbreviated AC, are typically common initial choices for mechanical ventilation in adult patients. In volume-controlled mode, the ventilator delivers a set, predetermined volume of gas with each breath, ensures consistent lung inflation. In assist control mode, the machine delivers that set volume or pressure with every breath, whether it's initiated by the patient or triggered by the set rate. It provides full support for each inspiratory effort. These modes ensure consistent lung inflation, provide full support. They're excellent starting points for many patients.
Okay, volume or assist control. Now, let's get into the specific initial parameters that define those breaths. What about the tidal volume? How precisely do we calculate that for a patient?
Right, tidal volume. That's the volume of air delivered with each breath. It should be set between 6 to 8 milliliters per kilogram of the patient's predicted body weight. And that's a critical point. It's predicted body weight, not their actual body weight.
Predicted. Okay, why is that so important?
Well, because using actual body weight, especially if the patient is obese, can lead to dangerously high tidal volumes. That can cause significant lung damage, what we call ventilator-induced lung injury, by overstretching that delicate lung tissue. Lungs don't really scale up with adipose tissue, you see. So accurately estimating that predicted body weight, often based on height and gender, is key here. It ensures lung protective ventilation. For example, for a 70-kilogram predicted body weight patient, you'd set the tidal volume somewhere between 420 to 560 milliliters.
Got it. Predicted body weight, 6 to 8 milliliters per kilogram. Next, the respiratory rate. What's the typical starting frequency for breaths per minute?
The respiratory rate, or breathing frequency, is typically set somewhere between 12 to 20 breaths per minute for an adult patient. This establishes a baseline breathing frequency, ensuring adequate minute ventilation, that's the total volume breathed per minute, and carbon dioxide removal. It provides a controlled, rhythmic breathing pattern that supports gas exchange. And this rate, of course, will then be adjusted based on the patient's carbon dioxide levels.
Okay. And oxygen concentration, often called fraction of inspired oxygen, or FiO2. Where do we begin with that to ensure initial patient stability?
You should initially set the oxygen concentration at 100%. Start high. This ensures immediate maximal oxygen delivery to the patient, providing a safety buffer during that initial stabilization phase. But then, you must rapidly titrate the oxygen concentration down. You don't want to leave them on 100% for long. The goal is to achieve a peripheral oxygen saturation, the SpO2, between 92 and 96%. This range balances getting optimal oxygen delivery to the tissues with minimizing the risks of oxygen toxicity and something called absorption atelectasis, which can happen with prolonged high oxygen concentrations. It requires careful, continuous monitoring and prompt adjustment based on the patient's oxygen saturation readings.
Right. Titrate down quickly. And finally, positive end expiratory pressure, or PEEP. What's the initial setting for that, and what's its main job?
Positive end expiratory pressure, or PEEP, is initially set to 5 centimeters of water. So start at 5 centimeter H2O. Think of PEEP like this. It keeps those tiny air sacs in the lungs, the alveoli, like little balloons that are partially inflated, even at the very end of exhalation. This isn't just about preventing collapse, though. It actively increases the surface area available for gas exchange, makes oxygenation much more efficient. It's a foundational setting that literally keeps the lungs open for business, you could say. It improves the functional residual capacity of the lungs, that's the air left after a normal breath out.
Okay, 5 centimeters of water to start. Now, setting alarms is absolutely vital for safety, for immediate problem detection. What parameters should we be setting alarms for on the ventilator?
Yes, alarms are critical. You must set appropriate alarms for key ventilation parameters. This includes alarms for high and low tidal volume, high peak inspiratory pressure, and low ventilation. These alerts are your immediate warning system. They highlight deviations from your target settings or indicate significant changes in the patient's condition. They signal potential problems needing immediate attention. They're a critical safety net, really, designed to alert you to things like circuit disconnections, tube obstructions, or maybe changes in the patient's lung compliance.
These are excellent starting points, but these are indeed just starting points, correct? What if a patient has specific underlying conditions, diagnoses that might require different settings from this general approach?
Absolutely. You've hit on a crucial point. This precisely emphasizes the critical need to customize settings. You must adjust those initial settings based on the individual patient's specific condition, their underlying pathology. Consider diagnoses like acute respiratory distress syndrome, ARDS, or maybe chronic obstructive pulmonary disease, COPD. These conditions require significantly tailored ventilation strategies because their lung mechanics and their gas exchange needs are fundamentally different. For instance, with ARDS, the goal is often lower tidal volumes, maybe closer to 6 milliliters per kilogram, sometimes even lower and higher PEEP, to try and recruit collapsed alveoli and prevent barotrauma, lung injury from pressure. In stark contrast, COPD patients often need longer expiratory times to prevent air trapping and what's called auto-PEEP. This might mean setting a lower respiratory rate or a specific inspiratory to expiratory ratio, sometimes as high as 1 to 4 or even 1 to 5. Customization isn't an option. It's a requirement for optimal lung protective patient care.
So while we have a solid baseline, the patient's unique physiology and pathology always guide the final individualized parameters. It really is a dynamic and personalized process.
Precisely. The initial settings get you started safely, but ongoing, meticulous assessment and continuous adjustment based on the patient's specific physiological response. That's what ensures effective and safe mechanical ventilation over time. The ventilator settings are living parameters. They're not static. They need constant attention.
Okay, the ventilator is meticulously set up. The patient is fully prepared. Now comes the direct connection process. And immediately after, how do we know it's working effectively? This really is the moment of truth in the entire process, isn't it?
It really is. Connecting the patient demands meticulous attention, precision, and immediate systematic monitoring confirms effective ventilation and actively helps avoid complications right from the start. This phase is all about vigilance and rapid assessment. Ensure that seamless transition and safety.
Before connecting, is there a specific proactive step we should take to optimize the patient's oxygen levels? Create a sort of safety buffer.
Yes, if it's indicated by the patient's pre-ventilation oxygen status, or maybe the expected difficulty of the connection, you should provide 100% oxygen via a bag valve mask before connecting to the ventilator circuit. This step is called pre-oxygenation. It's a proactive measure. It ensures adequate oxygen reserves are present in the patient's lungs and bloodstream during that transition from manual ventilation to mechanical ventilation. It actively prevents any desaturation that might occur during that brief period of disconnection and hookup. It provides a vital safety margin.
Okay, pre-oxygenate if needed. Once that's done, how do we physically connect the patient's breathing tube to the assembled ventilator machine circuit?
You connect the patient's endotracheal tube securely to the assembled breathing circuit. That connection point has to be robust, secure. Then you must immediately ensure all connections within the entire circuit are tight and free of any leaks at all. Leaks in the circuit, even small ones, can significantly compromise the delivered ventilation. The patient won't get the intended volume or pressure. This directly affects their oxygenation, their carbon dioxide removal. So a secure, leak-free connection is absolutely paramount for effective gas delivery and maintaining that positive pressure in the lungs.
Right, secure connection, no leaks. After that connection is made, what immediate crucial observations and assessments do we perform to confirm proper ventilation, verify the tube placement? What do we look for right away?
Immediately observe the patient closely. First, look for visible, symmetrical chest rise. That indicates effective gas delivery to both lungs. The chest should expand evenly on both sides with each ventilator breath. Second, auscultate. Listen for bilateral breath sounds. Use your stethoscope over both lung fields, confirm symmetrical lung inflation, proper air distribution. This helps quickly rule out a mainstem intubation, a critical error where the tube goes too far, into only one main bronchus, leaving the other lung unventilated or underventilated. Third, and perhaps most importantly, confirm tube placement and ventilation effectiveness with capnography. End tidal carbon dioxide monitoring. Capnography measures CO2 at the end of exhalation. It gives you immediate breath-by-breath confirmation of carbon dioxide coming out, clearly indicating the tube is in the trachea and effective ventilation is happening. These 3 steps, visual, auditory, and technological, provide rapid, critical feedback, essential for patient safety.
That combination sounds really robust. Visible chest rise, listening for bilateral breath sounds, and then the objective data from capnography. Seems like an immediate way to ensure safe and effective connection.
It absolutely is.
Okay, so connecting the patient is just the beginning, as you said. How do we keep the settings fine-tuned and the patient stable over time? Mechanical ventilation is definitely not a set it and forget it kind of situation.
No, absolutely not. What's truly remarkable here is the dynamic nature of ventilator management. It's constantly changing. Continuous monitoring and precise adjustment are fundamental to optimize patient care. A patient's needs can change rapidly, sometimes within minutes. That requires a highly responsive and adaptive approach to ventilation. You have to be ready to change things.
So first things first, how do we verify what the ventilator is actually delivering compared to what we've programmed it to do? Can we trust the machine's readouts?
Generally, yes, but you must regularly check the delivered volumes and pressures displayed right there on the ventilator screen. Think of it as ongoing quality control. It ensures the machine is consistently performing as programmed and delivering the intended support to the patient. It serves as a double check against any subtle discrepancies or potential malfunctions within the ventilator's internal system. Those displays should ideally match your prescribed settings, or at least show acceptable variance based on the patient's lung mechanics.
Okay, check the machine's display. But beyond the machine, what about the patient themselves? What physiological indicators should we be continuously monitoring right there at the bedside?
You should be continuously monitoring the patient's peripheral oxygen saturation, SpO2. That's your real-time, non-invasive window into their oxygenation status. Also, diligently monitor vital signs, heart rate, blood pressure, respiratory rate. These give you a holistic view of their cardiovascular and respiratory response to ventilation. And critically, always observe for any signs of patient distress. This might indicate issues with ventilation or their underlying condition worsening. Signs like increased work of breathing, using accessory muscles, agitation, changes in skin color, maybe an anxious facial expression, these demand immediate attention and investigation. These subtle cues are often the first warning sign that something is changing or going wrong.
Right, watch the patient closely. When do we need more objective, quantitative data, like a blood test, to precisely guide our ventilator adjustments?
You should obtain an arterial blood gas sample, an ABG, as needed. Typically, this might be every few hours initially, or certainly if there's a significant change in the patient's condition. This test provides objective, detailed data on oxygenation levels, PO2, carbon dioxide removal, PaCO2, and the patient's acid-base balance, pH. It's really the most accurate way to assess their gas exchange effectiveness and guide specific, data-driven adjustments to the ventilator settings. The PaO2, combined with the FiO2, helps you assess how efficiently they're oxygenating.
Okay, so once we have all this data, the ventilator readouts, the patient's physiological status from monitoring, and the arterial blood gas results, how do we actually go about adjusting the settings? To optimize both oxygenation and carbon dioxide removal?
Right. You use that data to titrate the settings. You adjust the oxygen concentration, FiO2, and the positive end expiratory pressure, PEEP, to maintain your target oxygenation levels. If the SpO2 or the PaO2 is too low, you might increase the FiO2. If that's not enough, or if the FiO2 is already high, you might increase the PEEP to try and recruit more alveoli, open up more lung. Conversely, if oxygenation is stable on a high FiO2, you should gradually decrease it to minimize oxygen toxicity risk. To ensure adequate carbon dioxide removal, you modify the respiratory rate or the tidal volume. If the PaCO2 is too high, meaning insufficient ventilation, you might increase the respiratory rate or the tidal volume to blow off more CO2. If the PaCO2 is too low, meaning overventilation, you might decrease the rate or volume. It's a constant, precise balancing act. Based on the patient's real-time physiological response, always aiming for optimal gas exchange with the least amount of ventilator support possible.
So it truly is a constant feedback loop between the patient's condition, the ventilator's output, the analytical data, all continuously guiding adjustments for optimal respiratory support.
Absolutely. Effective ventilator management is never static. It requires an ongoing, disciplined process. assessment, analysis, and precise adjustment. This ensures the patient receives the exact level of support they need as their condition evolves. It's about optimizing their respiratory function throughout their time on the ventilator while minimizing potential harm from the machine itself.
Okay, alarms. They can definitely be alarming, and they demand immediate, decisive attention. What are the key alarms we need to watch for, and how do we react to them quickly and effectively to ensure patient safety?
Yeah, this brings up a critical point about rapid response. Ventilator alarms are not nuisances to be silenced. They are urgent safety signals. Urgent. Prompt, accurate investigation and intervention are paramount. Ignoring them, even for a moment, can lead to severe patient harm, or worse. Your immediate response to any alarm is always patient assessment first. Look at the patient.
Okay, so what's the absolute first rule when a ventilator alarm activates? What do you do immediately?
You must investigate and respond to all ventilator alarms immediately. Never, under any circumstances, ignore an alarm or just silence it without first assessing the patient and identifying the cause. The very first step is always to look at the patient, not just the machine flashing lights. Assess their breathing, their color, their level of distress. Is the chest rising?
Right, patient first. Let's talk about high-pressure alarms. What are the common causes of these, and what are the immediate systematic actions you should take when one sounds?
Okay, high-pressure alarms. These indicate increased resistance to airflow going into the patient's lungs. Your first check. Look for kinks in the breathing circuit tubing. Is it compressed? Twisted somewhere. Next, check for secretions in the patient's airway that might be obstructing airflow. This often requires immediate endotracheal suctioning. Assess for bronchospasm. Is the patient wheezing? This causes narrowing of the airways, significantly increases pressure, and might require a bronchodilator medication. Also, consider if the patient is biting down on the endotracheal tube, maybe needs more sedation or a bite block. Addressing these causes promptly is essential. Reduces stress on the patient's lungs, prevents barotrauma.
Okay, check for kinks, secretions, bronchospasm, biting. And on the flip side, what about low-pressure alarms? What do those usually indicate, and what are the steps to resolve them quickly?
Low-pressure alarms typically indicate a loss of volume or pressure being delivered. Air is escaping somewhere. The immediate action. Check for disconnections anywhere in the breathing circuit. Start at the patient and work back to the machine. Could be a disconnection from the ventilator to the patient's tube, or a disconnection within the circuit itself. Hoses popped apart. Also, you must look for leaks. Leaks in the circuit tubing, or maybe around the endotracheal tube cuff. If the cuff isn't adequately inflated, air can escape around the tube. That's a common cause of a leak. A leak means the delivered volume isn't fully reaching the patient's lungs. It compromises ventilation. Both disconnections and leaks are serious. They compromise ventilation and require immediate, precise correction to get effective breathing reestablished fast.
Makes sense. Beyond just reacting to alarms, what about maintaining the overall integrity and function of the breathing circuit itself as part of ongoing safety checks?
Absolutely. Maintaining circuit integrity is vital. You need to proactively manage it. Regularly check the breathing circuit for condensation water buildup, which can accumulate within the tubing. Excessive condensation can actually impede gas flow, or worse, become a breeding ground for bacteria, increasing infection risk. Drain it carefully. Ensure proper humidification is consistently maintained. This prevents airway drying, which can damage the patient's respiratory mucosa, lead to thick secretions, and increase infection risk too. And lastly, continuously verify that all connections within the circuit remain secure. Tighten them if needed. Any loose connection can quickly escalate into a leak or even a full disconnection, compromising the patient's ventilation.
So it's clearly not just about reacting when an alarm goes off, but also proactive, ongoing maintenance to prevent issues from even arising in the first place.
Exactly right. Proactive checks looking for condensation, ensuring humidity, checking connections combined with an immediate and systematic response to alarms are fundamental for continuous patient safety. These steps ensure that the ventilation system functions optimally and provides uninterrupted support. Every component, every connection, every single breath truly matters for the patient's well-being.
Okay, beyond the machine itself, we know effective patient care relies heavily on precise records and, importantly, seamless team coordination. So, what does good documentation and clear communication actually look like in this demanding context of ventilator management?
Yeah, when we view this from a broader perspective, knowledge is most valuable when it's understood and consistently applied across the entire healthcare team. Documentation and communication, they're the essential elements that ensure continuity of care and paramount patient safety. They bridge that gap between individual actions and collective understanding. They create a cohesive care plan.
Let's start with documentation then. What specific information regarding the ventilator settings and the patient's response absolutely must be meticulously recorded?
You must document all ventilator parameters precisely, every single one. This includes the ventilation mode, the set tidal volume, the respiratory rate, the oxygen concentration, FiO2, and the PEEP level. This isn't just a snapshot, it's a critical record of care. Additionally, you must record any changes made to these settings. Include the exact time the change was implemented and a clear rationale why did you make that change. This creates a clear, chronological, and frankly, legally defensible record of care. It allows any team member to quickly understand the patient's respiratory support history at a glance, and it also includes documenting the patient's response, things like SpO2 changes, changes in work of breathing, ABG results if relevant to the change.
Okay, detailed documentation is key. And how absolutely critical is clear communication with the rest of the healthcare team? What specific information needs to be conveyed?
Communication is absolutely essential. Paramount. You can't overstate it. You must update the entire healthcare team about any changes to ventilator settings. That includes the nurses, respiratory therapists, physicians, other specialists involved. This ensures everyone is aware of the current plan and can coordinate their efforts effectively. Furthermore, you must clearly communicate any issues encountered with the ventilator itself, alarms, maybe malfunctions, or any significant changes in the patient's response. Increased distress, changes in gas exchange, everyone needs to know. Clear, concise communication prevents misunderstandings, promotes coordinated care, and ensures that the care plan stays consistent across all shifts and all disciplines involved.
Is there a regular rhythm or specific moments for reviewing these settings, maybe with the team or between shifts, to maintain that continuity?
Absolutely. You should reassess ventilator settings with every shift change, every single one. This ensures a thorough handoff. Current parameters, the patient's current status, any ongoing issues, any planned adjustments. It's a dedicated time for the incoming and outgoing teams to get on the same page. Also, you must review settings anytime there is a significant change in the patient's condition. For instance, a sudden drop in SpO2, an unexplained rise in CO2, a change in mental status, or maybe new lung findings on exam or imaging these warrant an immediate reevaluation of the current ventilator settings. This ensures the ventilator support remains dynamically appropriate for the patient's evolving physiological needs.
So it's really about creating a clear, shared understanding and a consistent mental model among the entire care team regarding the patient's complex respiratory support.
Precisely. Comprehensive documentation and clear, consistent communication are foundational. They're foundational for patient safety and achieving optimal outcomes in mechanical ventilation. They ensure that care is cohesive, continuous, and highly responsive to the patient's dynamic needs. It really is about teamwork in the truest sense, where every member is fully informed and aligned.
So what does this all mean for you, the healthcare provider listening? We've covered the essential steps for setting up mechanical ventilation, from preparing the patient and equipment with really meticulous detail, to fine-tuning settings based on physiological response, and responding to alarms with immediate action. Remember, always start with simple foundational settings and then personalize them with precision to each patient's unique needs and their ongoing condition.
That's right. Knowledge becomes most valuable when it's deeply understood and consistently applied in practice, every time. Vigilance for complications, responding to alarms immediately and systematically, and clear communication across the entire care team. These aren't just steps on a checklist, they are fundamental principles of patient safety. And this experience really highlights that consistent practice and deep familiarity with the specifics of each ventilation device you use are critically important for achieving proficiency and ensuring the best possible patient outcomes.
Mastering mechanical ventilation is truly a journey of continuous learning and adaptation. It never really stops.